Welcome to our faithful listeners for tuning in to yet another episode of the NailedIt Ortho podcast, where you learn about common orthopedic topics. We try to make the episodes within a reasonable amount of time and get you guys well versed on different topics. I am one of your hosts, Dr. Cole, and then we have our other host here on the line,
Dr. J Fitz, here back with you guys again.
Back again, like we never left. And today we have a great guest in store. We post great content actually on his Instagram. So we'll actually give you guys a link to all of his social media at the end of this. But I'll let Dr. Fitz go ahead and take us away here.
Yeah, absolutely. So we have a great talk today, and it's kind of just going over the basics of orthopedics. I mean, we talk about bone healing, we talk about different types of fixation, just kind of key topics that sometimes get overlooked in orthopedics, but it is really kind of the bread and butter and just the foundation of ortho. And again, it's Dr. Earhart. He did his residency at the McGaw Medical Center, Northwestern University. He did his fellowship in orthopedic trauma out at Case Western. And like we said, I think we may even met him from Instagram. He has a huge, I'm not going to say huge, but a nice size following on Instagram, and he puts out some great cases. So to this day, I still...
Very good.
I mean, great cases. I still save his cases now. If I'm at work and I see him post something, I save it so I can kind of go back and follow it now. So he's pretty amazing. We're going to get right into this talk. I don't want to waste too much of you guys' time. I want you to be able to fully immerse yourselves into this amazing talk. So we're going to jump right into it, guys.
Full immersion.
You are now listening to Nailed It, the Orthopedic Surgery Podcast, featuring Doctors Jay Fitz and Wendell Cole.
Okay, welcome to another episode of Nailed It Orthopedic Podcast. We have another great show in line for you. We have our guest speaker, Dr. Earhart, here. Coming in and spending a little time with us, going to teach us some of the strategies he used for just preoperative planning, which I'm really looking forward to, Dr. Earhart. I think it's going to be really good.
Thank you. I appreciate you guys having me.
Absolutely. So, personally, I think pre-op planning just is something that's, kind of forgotten, but we do it so fast that maybe we don't put as much thought into it as residents as we probably should. But so I'm looking to get a whole lot out of this talk. And but before we get too far, we always ask a few questions just to see, kind of, get to know our guests. So I have a couple questions here, nothing too much, not too many curveballs. With this first one, I was just going to ask, why did you choose trauma to go into for your specialty?
Yeah, I think I went into trauma for a number of reasons. First and foremost, I love the variety of it. I didn't really want to pigeonhole myself into one particular part of the body. I've always been really fascinated by musculoskeletal anatomy, and to be in a field where I have the opportunity to operate in all different parts of the body just was a big draw to begin with. I love that it's founded in very fundamental and well-proven principles. It's one of those fields where if you truly study the principles and how they apply to every case, it makes you a better surgeon, and it's founded in concrete principles, and that was something that always sat well with me. And then I personally really enjoyed the collegial nature of being a traumatologist. I certainly have my fair share of isolated orthopedic injuries, but when I have the opportunity to work with my colleagues, both within my own specialty and across specialties, to take care of complex patients, polytraumatized patients, it's a really unique aspect to being in this field, and that's something that I really wanted to.
Yeah, I think that's awesome. And I think actually just came back from AO Basic not too long ago, and they were just talking about those principles of trauma and fixation, and I just learned all that. So, I know exactly what you're talking. Well, I'm not gonna say I know exactly what you're talking about, but I have a general idea of what you could be referring to.
Well, I'll tell you, I think I know what you're talking about. A lot of people, a lot of my colleagues that are traumatologists, they remember their first AO basic course and who was their table instructor. I certainly remember mine, and I've had the privilege of working with him, in courses, since then. And he actually works not far from where I work. So that first AO basics course is a really special thing for.
It was a great course. So I guess the second question that we have for you is, what hobbies or interests do you have outside of the field of orthopedics that you like to do?
Oh yeah, I'm a bit of a sports junkie. I'm a Chicago sports fan, so I kind of try to put up with what the Cubs and Bears have to offer for me, which is sometimes good and sometimes not so good. I enjoy just being outside. I enjoy spending time with my family. I have 2 young kids, so nowadays when I'm not working, I'm just trying to find ways to spend time with my young kids. Have a puppy, love hanging out with my dog, and so we just do a lot of family stuff now. Just try to enjoy the nice weather when we're fortunate enough to have it here in Northern Illinois, and enjoy snowboarding when I have the opportunity to get away, and that's about it.
Oh wow, snowboarding. Okay, that sounds fun.
It is fun. It's very fun.
Sounds fun. Okay, so we're gonna go ahead and kick things off. I'm really looking forward to this particular talk. So it's going to be a little bit different. Usually we start off with a case with most of our podcasts, but I think this one I'm going to leave a little bit broad. Okay. So the big talk is going to be preoperative planning. And this is more so geared towards when you have that patient who comes in with this fracture, what goes into play as far as how you're going to go about the actual treatment of this patient. So, but before we get too far into it, can we just kind of get into some of the basic science of bone healing?
Sure, absolutely. So I think what's unique about fixing fractures is that you're really trying to find a marriage between biology and stability. And it really doesn't matter how you're fixing a fracture, what mode of healing you're going for. If you don't strike that balance, you're just not going to be successful. And an interesting kind of analogy that I was told a long time ago, and I'm embarrassed to say I don't remember the source of this, but a lot of people joke with me that I'm a carpenter, and I know it was at some course where it must have been an AO course, and whoever the speaker was said they're not really carpenters, they're a gardener, and it struck me. It was kind of like a one-off comment, but it's absolutely true. An orthopedic traumatologist is a gardener trying to make things grow. Our bones are alive, and our goal is to keep them that way. So whenever you're planning on fixing a fracture, it's important to first kind of break down those two aspects of how you're going to deal with that injury in terms of its biology, in terms of its stability. So when you look at the way that bones heal with that marriage, there's 2 modes of healing, primary healing and secondary healing. So I usually start with my residents talking about secondary healing, which is sort of the way our bones heal in nature. If we fall in the middle of the woods and we have no access to a hospital, our bones heal through this secondary mechanism. And really what it is, it mimics the ossification of development, and it's a multi-stage tissue differentiation process, which starts out with a inflammatory phase, no different than any other inflammatory reaction in the body. Where the bleeding bone creates the hematoma. The hematoma slowly over time will organize itself, form a scaffold, and then you enter a repair phase where that scaffold becomes a soft callus matrix comprised of kind of a cartilaginous material. And then over time, that soft callus will become hard callus as it begins to ossify, forming disorganized woven bone. And then that disorganized bone over time enters the final stage of remodeling, where cutting cones cut across and reorganize that woven bone into organized lamellar bone along the lines of stress for that fracture. So it's a very well orchestrated process. And if the injury has sufficient biology, sufficient stability, that process can continue. The other process is primary healing, and primary healing is essentially what I tell my residents. It's what separates us from the paper clips. So every day we walk around and we accumulate microscopic trauma to our skeleton in areas of particularly tension. And if we did not have primary healing mechanisms, those microscopic injuries would accumulate over time and turn into macroscopic fractures. We call them stress fractures, in clinical practice. And the primary healing process is what basically repairs that daily damage. So that's where cutting cones consisting of an osteoclastic tip basically eat across the area to be repaired, carrying with it a nutrient vessel and a tail of osteoblasts, which will lay down new lamellar bone along lines of stress, repairing that injury directly. And so this occurs without callus formation, and it only occurs in certain mechanical environments. So I try to, keep those two processes organized in my head, and think about those things when I'm preparing to fix a fracture. So that sort of deals with the biologic side. From a stability standpoint, what we think about then is the idea of the mechanical environment in which a fracture exists. And this is based on the work done out of the AO lab by Dr. Stephan Perrin back in the 60s and 70s. And without getting too nerdy or too long-winded, essentially what this is, it's talking about the strain at the fracture, essentially how much a fracture is able to move within the zone of injury. So strain is essentially when you take an object and you apply a stress and that object changes in length. It's the ratio of the change in length to the original length. And so the way I try to conceptualize it is if you have a fracture or fracture gap, the amount of motion or change in length at that fracture gap divided by the original gap is the amount of strain being experienced within that gap. So if, for example, if you have a 1 millimeter gap and that gap is able to move 1 millimeter, you have a pretty high strain environment. Whereas if it can only move 0.1 millimeter, it's a relatively low strain environment. And by taking that really simple ratio, you can use that to kind of devise the strain environment of a fracture. And if you can get the strain sufficiently low, meaning sufficiently stable, the body will heal through its normal secondary healing mechanisms. The interesting thing is when you can make that ratio 0, where there's absolutely no motion, absolute stability, that's where you can get a primary healing process. And that's, you can take those two mechanisms and put them together and kind of then move on to the basic AO principles of fracture fixation.
Now you're referring to, I think I recall this from AO, where, the amount of strain is somewhere like less than 2%, between 2 and 10%, and greater than 10%. Is that kind of what you're referring to when we're speaking about strain and everything?
Yeah, exactly. So if you have a highly unstable situation where the strain is, upwards of 100%, the body's only going to be able to form, granulation tissue, very flimsy and unmechanically sound tissue. If you get that strain down into, 10 to 20%, you might be able to form some scar tissue with a little bit more stability, but not bone. And if you can get it down below 5%, that's when the body is able to form callus and eventually remodel into lamellar bone through.
So when you see a fracture, like what in your mind makes you think, okay, well, I want this fracture to heal by primary healing versus secondary healing?
Yeah, so that's a really good question, and I think there are areas of gray for making that determination, with one major exception, and that's at an articulation. So articular fractures, we are obligated to fix or set them up for primary healing through anatomic reductions, generating compression, getting strain to 0 and eliminating any potential callus formation. So articular fractures require primary healing through absolute stability. Diaphyseal fractures, non-articular fractures, if they're simple, some can be treated with primary healing, some can be treated with secondary healing. Highly comminuted fractures, so highly comminuted metadiaphyseal fractures, we want to heal with secondary healing. And the reason we want to do that is we don't want to take a highly comminuted fracture. We don't want to go in and try to piece everything back together and potentially disrupt the blood supply and disrupt the biology any further than it's already been disrupted from the injury. So I think that those would be the two kind of absolute situations. So highly comminuted situations, biologically impaired situations, you're going to want to go for secondary healing, but any articular situation needs primary healing.
Absolutely. So let's see. In some cases, is it true that you can sometimes even do primary and secondary healing for certain types of fractures?
Oh, absolutely. I think that's sort of the next evolution in thinking about fractures and planning ahead for surgery. There are instances where within a single bone there are multiple zones of injury, and you're going to treat those multiple zones differently. I think the most common example that we think of would be a distal femur fracture with intra-articular extension. So if you have an intra-articular distal femur, you're going to want to repair the articular surface with an anatomic reduction and compression. But if that same fracture extends into the metaphysis and it's highly comminuted, you're going to want to bypass that area and allow that to heal through secondary healing mechanisms. So that can all be considered the same fracture, but each zone of injury might require a different construct and different modes of healing.
Okay. And so, all right. So now that we know about primary versus secondary healing, can we get into some of the different fixation constructs that are used in orthopedics now for, fracture fixation?
Yeah, absolutely. So when you're talking about let me take a step back. At the AO courses, what they're going to teach you is that, your internal fixation devices have a certain form and certain function, and you aren't going to obtain a function just because you have a certain type of fixation device. So when it comes to obtaining primary healing through compression, there are different ways that you can generate that compression. So there are compression through lag screw, which can be done, a lag screw can be done by technique or by design. There's compression plating, there's buttress plating or anti-glide plating. And I think am I missing one?
Oh, where's it?
I think that's it. So the point is you want to, so any one of those techniques is going to generate compression and allow for primary healing. Secondary healing can be achieved through different mechanisms that can include casting or splinting or slinging. Intramedullary nails, external fixation, bridge plating. So lots of different ways that you can achieve secondary healing. And so you can use the same implant to achieve those different mechanisms of healing by applying them in appropriate ways.
Now let's talk about the lag screwing and typically like kind of how that works. We have the near hole, far hole. Like how exactly does the lag screw work in achieving primary fixation and primary?
Yeah, so a lag screw can be done two different ways. So there's by technique, and by technique would be where you have an oblique fracture, and you're gonna over drill the near cortex up to the level of the fracture with the drill diameter equal to the thread diameter of the screw, and then you're gonna drill the far cortex with the core diameter of the screw. So then that gets you into kind of more of a screw anatomy. So screws have a core diameter, which is the shaft, and then they have a width to their thread. So by drilling the width of the thread on the near cortex and the core diameter on the far cortex, and then by countersinking the near cortex to apply even pressure as the screw comes down, it's going to engage the far cortex and draw it towards the near cortex, generating compression. To do it by design would be to take a screw that is only partially threaded, where you don't need to over drill the near cortex, and it only has threads to engage that far cortex for you.
And when you say that, just that term, to over drill, is that the whole process of drilling the diameter of the screw and the near hole?
Correct. So you're drilling the thread diameter of the screw. So for a 3/5 screw, a standard small fragment screw, you're going to drill 3.5 millimeters on the near cortex so that the threads don't have the opportunity to engage. And then the far cortex, you will drill at the core diameter, which for most standard screws is 2.5 millimeters. And then that changes, obviously, depending on the size of the screw.
Okay. That's like, I know they probably hark that at AO, and I know my colleague, he gets in the OR a little bit more than I do, but I know that's like one of the first things you might learn is when you step into OR suite with orthopedic. We use this technique quite a bit. So that's good I'm really glad that you was able to break that down. Can we kind
of touch on achieving primary or absolute fixation or stability through compressing through a plate and kind of how that works?
Yeah, so that can be done in different ways. Compression plating can be done using the design of certain plates. If, let's say, you have a transverse fracture of a long bone, a diaphyseal fracture of long bone, you can secure the bone or the plate to the bone on one side, and then once it's secured on one side, you can drill the second screw on the other side, but you drill eccentrically within the hole designed for that screw. You basically put the drill as far away as you can from the fracture site within the screw hole, and then as the screw goes down, the rounded screw head will engage the plate, and as you continue to tighten it down, it will basically draw the plate over, which essentially pulls the fractured ends of the bone together. You can do that actually sometimes more than once, 2 or 3 times, and each time generating about 1 millimeter of compression. There's other nuances to that technique, but that's essentially the idea behind a dynamic compression plate. The other way that you can generate compression through a plate would be to use a push-pull technique by placing a screw outside of the plate on one side of the fracture, and then using a clamp called a vibrouge. You stick the vibrouge into the plate and then around the screw, and by squeezing that clamp together, you can draw the fracture together if it's already fixed on one side. So that's, again, using a technique called a push-pull screw.
Okay. And so I guess first so that was a compression plate. And we talk about, I guess, like a locking plate as well.
Yeah. Locking technology is that's a whole big can of worms. Locking plate technology essentially is where where the screw threads into the plate, creating a fixed angle at the screw plate interface. The idea behind that is that the plate will fail by a different mechanism. So this technology was originally designed for osteoporotic bone in the proximal humerus, and the idea is that standard screws, which don't engage the plate, are able to toggle back and forth within the plate. And so if you have bad bone and you can't generate sufficient torque between the plate and the bone, over time, those screws can basically kind of windshield wiper back and forth and loosen, and they can sort of all fail at once catastrophically. Locking plates allow the screws to lock into the plate. They don't generate any torque of the plate against the bone. They gain their stability by creating a fixed angle purchase into the bone, whereby you can imagine, in order for that to fail, the screws would have to fail all at once, cutting out of the bone catastrophically. And so it creates a stronger mechanical fixation in bad bone. And I believe I misspoke, actually. I apologize. So for standard plates, they can fail sequentially. So because those screws can toggle, the plate can lift off the bone as the farthest screws toggle and loosen more, and then they can sequentially loosen more and more, allowing the plate to fail. With locking fixation, the entire plate would have to fail at once.
And while we're on it, can we talk about working length and kind of its importance in dealing with fractures? And since we're talking about plates and different screws.
Yeah, so working length is a term that kind of jumps to the other side of healing. So that's for callus formation, secondary healing. Working length refers to the distance between the screws closest to a zone of injury on either side of the zone of injury. And so the idea being that when you bridge across a comminuted fracture, with a bridge plate, the idea is that you want to leave enough distance between your fixation proximal and distal to the fracture to allow for sufficient micromotion to create that low strain environment that will allow the bone to heal. I think one of the things that orthopedic surgeons struggle with is how to gauge what that proper working length is. And that's certainly a challenge that we don't have a quantitative solution for at this point. That's sort of the art of fixation in those comminuted fracture patterns.
And since we're also talking about plating, I guess the whole thing is on plating. Can we kind of touch on the difference between buttress and an anti-glide plate, like how the plate is used?
Sure. Yeah. So I've heard differing opinions on how those two terms are used differently. I think the most important thing to keep in mind is that both of those plating techniques are designed to resist shear, and they are both designed to generate compression. So at the end of the day, they're both kind of doing the same thing. So in a fracture that is susceptible to shear, you are using that plate device to generate compression at the apex of a fracture and prevent a segment from shearing. Buttress is a term that gets used in the articular setting. So when you have a partial articular fracture, most classic one would be the longitudinal split of the lateral plateau. That fracture is highly susceptible to shear. And so a buttress plate will place a screw at the apex of that fracture, which compresses at the apex and also creates an axilla that prevents that fracture from shearing distally and displacing. In the AO, they talk about articular fractures as A types, B types, and C types. B types are the partial articular fractures, and the saying is that B is for buttress. So that's where that term gets used. Anti-glide is just another anti-shear compression generating device, but that's the way I understand it for diaphyseal fractures, so for non-articular fractures. And the classic example would be the distal fibula. So you can have a Weber B or a Weber C oblique distal fibula fracture, and by placing a plate at the apex of that fracture and then a lag screw through the plate, you can create an anti-glide device which will resist shear and generate compression.
Nice. Okay. So we've been talking about some of the devices that we use sometimes for, most of them, I know you can possibly use them for absolute stability. So what are some of the techniques that you will use sometimes for, relative stability for some of these fractures?
Yeah, so it sort of depends on the fracture and the clinical scenario, but the most common secondary healing, relatively stable devices would be external fixators, intramedullary nails, bridge plates, and frankly casts or splints. So all of those allow for relative stability and relative micromotion if done correctly, and callus healing. We use those different techniques for different fracture types in different parts of the body. And, but again, the goal is the same. And I think sometimes that gets lost. We look at certain fractures and we're sort of instinctually thinking that we're going to use one device or another, when what we should be thinking about is what mode of healing are we shooting for?
Okay, absolutely. I think this was really good because, just sometimes getting a good understanding of all the different types of techniques and plates that we have is I don't know, it's a lot to grasp, especially for someone who just kind of new to it all. So I think that was very helpful. I know this whole talk was really about preoperative planning. Just, is there something a way that you kind of sum this up for all of your patients? Because it's a lot to kind of keep in mind. You got to keep in mind about the patient, the fracture, and I guess what's the actual goal. So how do you just kind of put all this together when you looking into a new patient that you get about for a fracture?
Yeah, that's a really good question. It's a huge, if you're going to be very cerebral about it, it can be a very kind of daunting task to preoperatively plan a complex patient and a complex fracture. But I think that the way that has worked best for me and the way that I try to teach my residents to do it is to first sort of think about the ideal situation. We're taught to treat our patients, not to treat x-rays, but I think it's sometimes helpful, especially early on when you're learning and when you're in practice early on, to sort of look at each individual fracture and first decide what is the optimal way to treat this injury, looking at it as an x-ray. And so that sort of eliminates some of the patient-specific factors that can sometimes change what you would do from the ideal setting to an alternative approach. So what I try to do first is look at the injury and break it down into its component parts. So sometimes we're lucky and we get a fracture that is fairly simple, and it's an isolated injury to a single segment or portion of the bone. Easy to kind of classify and easy to describe. And we can take that injury and sort of ask ourselves how we want it to heal. Sometimes we look at injuries and they're much more complex. So you can get a patient, for instance, who has perhaps a bicondylar tibia plateau, and then you look more closely and you realize they also have significant extension into the shaft that's comminuted. Then you look closely at the lateral and you notice that they have a free tibial tubercle component. So each of those components of that injury may require different modes of treatment and different modes of healing. So I think the first thing that I try to do is I try to organize a list of all the problems that I have to deal with, starting with the components of the fracture and then the other associated injuries, like whether or not it's an open fracture, whether there's compromised soft tissues, et cetera. Once I've made a list of all those injuries, I've then tried to teach my residents to first decide how you want that injury to heal. And I think that that's sort of a step that gets lost a lot of the times when residents or even when attending surgeons, try to attack an injury, is that they go immediately to the construct or they go immediately to the approach, and they don't stop and think to themselves, how do I actually want this bone to heal? What's the optimal way to get this bone to heal? And what's nice about doing that is that not only can you come up with, perhaps the most appropriate construct to achieve that goal, but then you can come up with plan B and plan C and plan D, because you don't always know what's going to work in the operating room. Sometimes you need to bail out because your first go at it doesn't work out the way you had expected. The best example I would give of that, and sort of what got me turned on to this topic, as an educator and as a surgeon, was I used to ask my residents, we would get a bimalleolar ankle fracture, and they would take a look at it, and I would ask them, what their plan would be for treating this injury. And they would say, well, I want to do a lag screw on the fibula, and I want to put on a 1/3 tubular plate, and then I want to put in a partially threaded screw on the medial malleolus. And I would say, okay, that sounds pretty good. That's fine. And we would go to the operating room, and sometimes that plan would work and sometimes it wouldn't. And it's when it wouldn't that was the most interesting, because if you're not thinking in terms of modes of healing, you're not always ready for that failure. So now what I say to them is, okay, how do you want that fibula to heal? So say you have a simple Weber B, oblique distal fibula fracture. And they say to me, well, it's a simple oblique fracture. I want that to heal by primary healing. And I say, okay, that's great. How do you want to achieve that goal? And most of them will say to me, well, I want to do a lag screw. And I'll say, okay, that's great. We're going to try that lag screw. Now, let's say this patient has bad bone and you put in that lag screw and it just has no purchase whatsoever. The bone is too soft and you're not generating any compression. Are you going to give up and just kind of bail out and put a plate on and call it a day? Or are you going to find an alternative way to achieve your goal? And the reality is, if you think of it this way, you'll recognize that if a lag screw doesn't work to achieve compression, you can bail out to an anti-glide plate. So you can put in that anti-glide plate device, which is mechanically a lot stronger in osteoporotic bone, and it is a great way for generating compression in the same way that a lag screw would. And so I'll bail out to that if I have to. Same thing with the medial malleolus. So if we try to put in a lag screw in the medial malleolus and it just doesn't gain a lot of purchase. Well, how are you going to bail out on that? Well, you might try putting in a tension band plate instead. A tension band plate can generate as much or more compression as a lag screw and achieve the same goal for healing. So that's sort of what I'm getting at when I talk about preoperative planning. You know, there's certainly the AO technique of tracing out fractures and, you know, writing out your reduction sequence and writing out your plans. But I think if you really take a step back and you go to that highest level of how bones heal, you're going to be prepared not only for how you think you're going to treat something, but how you're going to bail yourself out if it doesn't work.
I think that was a great talk. I think that was a great explanation. I really hope people really pay attention to that last point you just said of how to look at fractures and have, you know, a plan A, but also a plan B in case your first thing doesn't work. I think this was a great overview. Dr. Earhart, really want to say thank you for your time and coming and speaking on this podcast and helping us educate the people. I think it was a really good talk. Now, thank you all for listening to that episode of the NailedIt Ortho podcast with Dr. Earhart. I think he did a really great job kind of going through pre-op planning and really breaking it down. So I hope you guys really enjoyed that. You know, we also just wanted to point out that we also have, you know, tension band wiring, which changes tension forces into compressive forces. You all can kind of read and look that up. Go to NailedItOrtho.com to find our show notes. And don't forget to subscribe and follow us at Instagram at NailedIt Ortho.